On to the next talk, myths and facts of open globe injuries in RTA. It's Dr. Subhadra Jalali.
As everybody knows, Dr. Subhadra Jalali is a renowned ROP, especially. She has got a very good name in the country and outside also, in the world also. So she will be speaking on myths and facts of open globe injury. Thank you.
Yeah, I deal with trauma also. So let's see some of the myths and facts of these things. So these are the important things, especially from the community point of view, that if there is no light perception, this we learned from the Israeli group on trauma, who have done a lot of work on trauma, being in the war zone all the time. Same thing for us in Kashmir. So if you check the no light perception, which we are taught in medical college or in our ophthalmology residency, has to be done with an indirect ophthalmoscope. So it is presumed that the indirect ophthalmoscope light is the brightest light, and that is why it was mentioned. But we did a study where we used the ERG flashlight, and we found people who were not responding to no PL with the indirect light actually responded to the flashlight of the Gansfeld, which is like really 10,000 times brighter. So just to say that this no PL is a subjective test. There is no objectivity to it. Patient is in trauma. They may respond, they may not respond, and sometimes they, because the eye is full of blood, so they can't actually see the light like we see in a normal eye. So we ask like light dikhta hai, nahi dikhta, he'll say nahi dikhta, but sometimes they can see a glow. So now glow is different from light dikhta hai. So what we are asking, what the patient is telling, so this no PL should not decide what treatment we are going to give. So I have so many patients where somebody wrote no PL in the emergency, and after proper treatment, patient has got 20/40 or 20/100 at 636, even 612 vision. Why this happens? That's what exactly I'm saying, and there's published literature also. So while we do document PL, no PL, but the treatment should depend on what is the pathology of the tissues. So this is one myth I want to break. Of course, people who come with PL, no PL vision, their prognosis would be poorer. It's not that all of them are going to get vision, but that is not what should decide our approach to the patient. Second is hypotony. So whenever there is a detachment or there is an open globe, or even if you have repaired an open globe, because of the underlying detachment, ciliocoroidal, retinal, patient can have hypotony, so pressure can be zero or non-recordable. That does not mean it is phthisis. Just because the eye is looking smaller or the pressure is zero, it is not phthisis. Phthisis takes at least 5 to 6 months. It's a pathological diagnosis where the tissues are replaced with fibrous tissue, calcified tissue. So that's a very different disease. In acute phase, we should not label anything as pre-phthysical, going into phthisis, become phthysical. So we should just say this is hypotony. And hypotony we need to manage by putting silicone oil, by doing treatment of the cyclodialysis cleft, by putting back the retina in place, by looking at any wound leak. So there are various causes why the eye could be severely hypotonic, inflammation. So we must treat that hypotony and treat the pathology and not label it as pre-phthysical till it really is pre-phthysical or phthisis. The other thing is like only little is gained and much time and effort and money will go into the surgical repair. So if there is a big wound and there is sort of PL, no PLI and all. So people used to do primary enucleation or primary evisceration, saying that now we are going to save the sympathetic ophthalmitis. This is completely not acceptable in today's microsurgical era, where we can really salvage a lot of these eyes if we do the proper thing at the proper time. And you never know what will happen to their good eye, and the risk of sympathetic ophthalmia is very, very low. And even if sympathetic ophthalmia occurs, it is treatable. So we should not do any primary enucleation. We should always give a chance to that eye to recover, to repair, and then once you've done the primary work for a few weeks, months, then you make the decision whether there is, it's unsightly, it's really phthysical, and then make the decision. But otherwise, most of these eyes, if you repair properly, they can get useful vision or even globe preservation. Now the other very important myth is that कि आपको तो चोट लग गया इसलिए आंख खराब हो गई. So to say that most of the damage has occurred during the impact, and the surgeon has no role to play for the ongoing damage. So this is a very important concept, that the trauma is there, it's a bad case, it's a road traffic accident or whatever, it's very badly slashed eye, but there's an ongoing damage which is happening, which the surgeon can stop. by doing the immediate primary repair, by giving lot of steroids, giving antibiotic in case we are thinking that there is going to be endophthalmitis, giving intraocular antibiotic during the primary repair. So if you do these steps, then you are preventing ongoing damage. So the primary injury is there, but there is an ongoing damage from inflammation, from infection, from open globe, and from not doing the proper thing. So the surgeon, the primary surgeon who's seeing in the field, has a lot of role to play, including, of course, without saying, giving an injection of tetanus toxide. If it is open globe injury, that's mandatory, legally mandatory to give tetanus toxide by the person who sees the patient first. There are other myths and facts, which is like vitreous hemorrhage can be followed up. We should do blind cryopexy. All blind eyes have to be enucleated, and most important that after injury patient should be on complete bed rest, otherwise the retina will detach. No, the retina doesn't detach because of physical activity. It's a biochemical nature of the injury and the biochemical adhesion of the retina to the RPE which makes it attach or not attach. It's not like by walking or running the retina is going to detach. So these are some of the myths I wanted to break in my presentation. Thank you.
I think ma'am has very elaborately conveyed a wonderful message for all of us, that a surgeon must have the courage to deal a situation where you feel that the prognosis is very poor, or you are desperate. But we should have the courage to beat the situation. Number one. Number two, madam, I wanted to know, you have recommended enucleation for all blind eyes.
I said no. I said there is no recommendation for. I said people think. Yeah.
It's the other way around.
Yeah. So because of lack of time, I didn't show cases.
We have seen a case of sympathetic ophthalmitis.
That's what I said. I said in the past, the past, that is what people used to counsel. That's a myth. That's a myth. Don't remove these eyes. Let them be there. Good cosmesis can be achieved, and the risk of sympathetic ophthalmia is not there if you have closed. So for the primary surgeon, important is to get that wound to be closed. And then what we find is that they refer the patient after a month or so. That's not to be done, because the second surgery for the retina must be completed within 10 to 15 days. Then only you can salvage that eye. So do the primary repair, start on systemic steroids, start on oral antibiotics if you want, start on oral steroids, heavy dose, and then immediate and topical 2-hourly steroid, and immediately refer to the vitreoretina surgeon. So they will evaluate, and now because of endoscopic surgery, because of good what we say small incision vitrectomy surgery, we are able to operate them within 7 to 10 days, and that is the best time to do the retina surgery. If you send after 1 month, then the retina has already got completely scarred.
Provided media is clear.
No. Even in unclear media, we can do primary PK, we can do endoscopic surgery. Now endoscopic vitrectomy, in many of the centers it has already started. We are doing for many years. But in good centers, we will have endoscopic surgery. So even if cornea is opaque, we can go from behind and do the surgery and not do a PK. Endoscopic vitrectomy.
Many times the root therapy accident cases, two things happen. From the medical legal point of view, the people, whoever they are not touching the cases, they report late. Second thing, it's reported, once it's reported by the primary care physician, what he has to do.
Yeah. So
before he's referred to the ophthalmic surgeon.
Yeah, so they have to make sure that patient doesn't have head injury, all those points like CSF leak, any history of vomiting, because sometimes they land into ophthalmology OPD without having seen a neurosurgeon or neurophysician. We cannot take them up. So so the life is priority, the CNS injury is priority, they could be chest injury, they could be having breathing problem, they may die in your OPD, in your emergency. So that primary first aid and assessment of the patient that there is no other vital organ injury, liver rupture, that can be silent, patient can die there. So all those things the general surgeon, neurosurgeon has to evaluate, do the CT scan or do the abdominal ultrasound or whatever. That is the priority. So even if they come to your eye hospital first, you put the IV line, stabilize and send them to the main hospital.
That's a wonderful message.
Yeah, that is very important. Life has to be taken
cases,
first.
We should have a multi-specialty approach. You cannot bank upon your own specialty.
Yeah.
Look to the general condition of the patient.
Yeah,
look into
BP,
the
pulse,
history part
and document it.
And decide
Yeah.
if the patient requires opinion of other specialists, go for that.
Yeah,
It
we
has to
know.
be a team management.
Yeah, we
It
know
is very
bleeding through
important,
ENT. This is taught in MS. Bleeding through ENT, CSF, right? Unconsciousness, all these things we have to send there.
May I request Dr. Mayal sir to come and give your comments on this, discuss?
In an open glove injury, usually we don't put an antibiotic drop. Usually we just put an eye shield or an eye pad so that people don't put things into the eye and then, do the repair usually within 4 to 6 hours. And if it is less than 12-hour injury, give intracameral or intravitreal antibiotic, vancomycin, at the time of the primary repair.
But directly antibiotic drop should not be given.
Antibiotic drops we should not put because we don't know what is going inside the eye.
Yeah.
Thanks, Dr. Subhadra Jalali.